All right, we're going to get started tonight on geriatric emergencies. It's kind of it's not a long chapter, but it's kind of long. So we'll dive off into this and we'll get going from here tonight. So talk about special patient populations. They are a special population because of being the geriatric part. We tend to run a good bit of these in our normal response through EMS. We'll go over the impact age-related change and assessment of care because we're going to have to adjust some of our care. It's still going to be ultimately all the same, but when you go to, think about how medications work, to, the skin, to things like that, we need to be concentration on that. So we'll go over tonight we'll talk about cardiovascular, respiratory, and neurologic diseases, endocrine, Alzheimer's, dementia, we'll talk about, and we'll kind of do the same thing as we did the other night about abuse and neglect for the elderly. Trauma's a little different. Their bodies don't function as well. Majority of the time, trauma is dependent upon how healthy an individual is and how well they respond to a traumatic event. So being the elderly and things are, I'm just going to say, worn out, that things change a little bit. Their overall take of medicine, their overall just drive and their heart, blood pressure, things like that, are going to deviate just a little bit. Special considerations in trauma, recognize the management of trauma with a geriatric patient. We're talking about patho and physio and the management of a geriatric patient. So why is this in my way? So geriatrics is the assessment and treatment of disease in a person who is 65 years of older. So that is your key thing. It goes from geriatrics when you start to turn 65. It is projected that between 2012 and 2050, the population aged 65 years and older is expected to nearly double. I guess that's good for me. Geriatric patients present as a special challenge for healthcare providers because of the classic presentation of injuries and illness are often altered by the presence of chronic conditions, multiple medications, and the physiology of aging. That's about normal. We know those things with just normal getting older in ourselves, we notice things change and how we deal with things. All right, so here it's important that you understand and appreciate how life of an older person may differ from yours. What do you do versus what they do because of maybe special situations? They may get tired faster, may have a respiratory problem, they may be on oxygen, could be on LVAD due to cardio output problems. It takes time and patience to interact with the elderly patient. Always treat them with respect. Remember, those are our forefathers, and they're the ones that kind of built where we are right now. Because I've always demanded my kids just provide the respect. I'm not asking for them to get it back, but no matter what, you respect your elders, and that's how I raised mine, and that's how I was raised. Is these people are this generation's a little bit slower when it comes to things. The geriatrics, I like the stories. Now, back in my time, and I'm sure it'll come to me one time to say that. So we want you to make every attempt to avoid ageisms. Oh, you wouldn't understand, and the stereotyping of elderly patients that often leads to discrimination. Older people can stay fit and be active even though they are not able to perform at the same level you did as they did in their youth. We know that things just don't function like they did when they were younger. All right, so here, effective verbal communications are very important to the essential assessments, your treatments, and just knowing how the elderly patients are. Communication with elderly patients can be challenging. Changes communications abilities accompany aging, such as dementia and other diseases. Communications, when caring for an individual, use their name to communicate. Don't if you don't know them, call them sir, ma'am. Asking the patient how he or she prefers to be addressed can help you. Don't only hey love, how are you doing? What's up, baby? That may not be in their liking. They may not like that. They want to know who you are. What are you there? And they are aware of your presence no matter what. So look at them in their eye. Let them know what's going on. Let them know what you're there for. Make sure that they can see you. Hey, sir, I know it's a little dark in here. I just want to make sure you can see me so I can talk to you and tell you what's going on. So those may be something that you address and that you can and that way you can stand by. I'm trying to answer a message. So again, looking at them directly is going to help you out and build that trust as you go further into this. Have one person talk to the patient and ask one question at a time. Do not assume that all older patients are hard of hearing. Not happening. They may not be. They may hear better than you. Give the patient time to respond unless the condition appears urgent. Listen to the answers the patient gives you. Give them the same respect that they are giving you to speak fully. Get your question out. Listen. If you have a question, make sure you just note it and you go back to it. Explain what you're going to do before you do it. Do not talk about the patient in front of him or her as though the patient is not there. That is disrespectful. It's the same thing as a child. You may have to just exit the room or tell somebody, hey, do you mind if I speak to you out in the hallway? It's the same thing with elderly. We just have to adjust it a little bit in the age type. Some of the common complaints that we get is the changing physiology of a geriatric patient is a predisposed in this population to the host of problems you're not going to see in their youth. A simple rib fracture in an 80 or 90-year-old can result in pneumonia or even death. It's not gonna. Their health does not allow them to get any healthier. A hip fracture from a low mechanism fall, just walking around, slip, trip, and fall, is common in this age group, and the people may have dire consequences. Hip fractures are more likely to occur when bones are weakened by osteoporosis or small infection. Sedentary behavior while healing can predispose the patient to pneumonia and blood clots. So they got to get up and move. With them being able to just stuck in the bed, the blood clots are going to. That's why you see a lot of the elderly with their socks on when they're in the hospital. Many older patients who experience hip fractures do not return to their pre-injury level of activity without a lot of PT and the will for them to want to get back to being independent. There's you a chart of common conditions leading to causes and death of geriatric patients. Let you look at that for a second. Maybe. Some changes in the body, what we're going to go over here. Human growth and development peaks in the late 20s and early 30s, at which point the aging process begins. The aging process is an event, and it's not, you can't hide from it. It's going to happen. And changes in the physiology functions, such as decline in the functions of liver and kidneys, is just going to slow down. All tissues in the body undergo aging. The decrease in functionality, capacity of various organ systems is normal, but can affect the way in which a patient responds to illness. Kidneys, you may not be able to pee as much, or you may not be able to hold it as longer. That's why they got to go to the bathroom all the time. Some of the age-related changes can predispose in elderly patients resort to respiratory illness. You'll have weakness of the airway muscular, and it can cause decreased breathing capabilities. The alveoli can become enlarged and elasticity decreases, making it harder for use to expel the air. Chemoreceptors slow with age, causing the body to respond more slowly to hypoxia. They're not going to be able to get that and try to get back up to it. Loss of the mechanism that protects the upper airway includes decreased cough and gag reflexes. So they may, I don't have no way to buckle down. So they may have to start chopping their food up a little bit smaller because they're going to get coughed up a little bit more. And then they may not be able to take pills as much. They may have to have like a liquid form. Pneumonia, chronic lower respiratory disease is influenza and pneumonia are in the top 5 causes of geriatric deaths, which is sad. That is preventable, and we can potentially help them. Now, we're not gonna make them, you know, heal and never get pneumonia, but we can help prevent that, shall I say. Inflammation or infections of the lung of the from bacteria, viral or fungal causes this. Leading cause of death from an infections in Americans older than 65. That's sad that pneumonia and these lower respiratory diseases, that's a pretty big cause. Aging causes some immune suppression and increases the risk of contracting infections such as pneumonia. You'll have increased mucus production, pulmonary secretions, and the inflammatory effects the infection all interfere with the ability of the alveoli to oxygenate the blood. So you may not carry as much reserve oxygen around because now the body is just like, I don't know what to do. I'm tired. I'm just not happening no more. So management in pneumonia is the same for any patient. You're not going to change it just because they're geriatrics. However, maintaining a high index of suspicion for a geriatric patient with signs and symptoms of pneumonia. I gotta answer that real quick. All right. So pulmonary embolism. So this is going to be also referred to as a PE. So a PE is a cause of sudden blockage of any artery by venous clots. A patient with a PE will present with shortness of breath and some chest pains, and it can be confused with you can confuse it with a cardiac, a lung, or musculoskeletal problem. Be very detailed when you assess these, even though that they complain of cardiac related problems. Do your assessment thoroughly. Sorry, my mustache is bothering me. Be very thorough in these assessments. Auscultate their lung sounds. Make sure that you provide a lot of close attention to these types of calls, so that way that you're not going to miss something. Some of the risk factors that include are living in a nursing home or recent hospitalization from medical illness or surgery, trauma, cancer, history of blood clots and failures, presence of a pacemaker or central venous catheter, paralyzed extremities, you have obesity, smoking, and recent long distance traveling. Now, this is only for the elderly. So the recent long distance traveling of PE is because they're not getting up and moving around. That limits things. So you're not going to have that blood flow moving around like you normally would. Patients will present with anxiety, cough, syncope in the patient when the clot is larger than normal, shoulder, back, or chest pain, sudden onset dyspnea, and tachycardia. What's yours say? Age-related change in percent? Okay. Okay. Just want to make sure I'm on the same page. So let's see. Is y'all screen changing or is it just mine? Okay. What are y'all, like mine is just stuck on, obviously my other screen's not working. All right, good deal. So y'all are looking at PEs presents with, is that right?
Yeah, continued.
Yeah, my other screen has just decided to say not tonight. I do a sidecar with my Mac, my Apple, my iPad over here, and sorry, it wasn't changing. That's why I was like, what's the deal over here? All right, so PEs, so you present with a low-grade fever. You can have leg pain, redness, and unilateral pedal edema because what it's doing is it's got a clot and it's forming, and now you're not getting the fluid back, or the blood clot is blocking the blood exchange. So what you're going to basically do is, as basics, you're going to be supplemental oxygen and supply ventilatory supportive needs. So they may need to be bagged. May be able to provide a bag valve mask. Let me see if I can. Oh no, what just happened? Stand by, y'all. I don't. Y'all hang on 1 second. Touch the screen and it decides to not work. Sorry. Let's try this again. It is not wanting to work for me tonight, so I'm just going to have to go off my main screen here. So let's see if I can get it to work this way. All right, so now we're on the same page here. Everybody see this? I can't see anything. All right, y'all, give me just a minute. I'm sorry, everything's wanting to freeze up on me, so hang on 2 seconds, y'all. Can y'all see that again now? Are we back on the same page? Somebody just let me know what y'all are seeing. Changes in the cardiovascular system, 1 of 5. Is that right? All right, good deal. Sorry, I'm blaming it on the weather about that. We'll leave it my story. So here. All right, so in the patho part was just going to talk about the ability to speed up contractions. We'll talk about increased contraction strength in the constrict or narrow blood vessels. It's going to be part of the reason. So we'll look right here on this picture. So this is going to be normal. And as you get older, you're going to have the arteriosclerosis. And you would know deer pictures start to come in. So that's kind of important too. So you're looking at the constrictors of the blood vessel. So normally we're going to be about right here. And so after a long time, we're going to get to here, and then it's going to get smaller because all the plaque is building up inside. You have your calcium buildup. All that's going to cause issues as we get older, and it's not like we can just go in there, get rid of it. We try to take some OTC meds or prescriptions that can help prevent with that, but sometimes it's just not. And there's some with it being so small, that's where your clots form. Older people are also at an increased risk for the information of a for formation of an aneurysm. That is a severe blood loss and can occur when aneurysms rupture. The blood vessels become stiffened, which results in higher systolic blood pressure, stiffening, and degeneration of the heart valves that may impede normal blood flow in and out of the heart. So the electroconduction system of the heart undergoes changes. So you're going to see different heart rhythms. You're going to see abnormal rates. It's not going to be what is textbook, and that's what we're looking for. But you'll start to have these funny things because there's, I'll call it a fuse. There's the fuses are worn out. They tired, boss. They just need a break. But if they break, they're potentially going to pass. We don't want that. So orthostatic hypertension is a drop in the blood pressure, which changes in position. So when you have them seated, you check their blood pressure. And then when you stand them up, you're going to notice the drop of the blood pressure. And that's what's going to let you know that it's a cardiac event. They may get lightheaded. So when you go to stand anybody up from an event, make sure you stand them up and you hang on to them. That way that you can check on them. How do you feel right now? Tell me what's going on. I don't know. I don't feel so good. I feel dizzy. Sit them back down. Check your blood pressure and change arms. If you started in the left arm, change it and go to the right arm when you stand them up. So the venous status can also cause clots to develop in the veins. This is the leading to the deep vein thrombosis or pulmonary embolisms. Loss of proper functions of the veins in the legs that would normally carry blood back to the heart is going to change. Trying to figure out getting all these messages at one time. I guess service is finally coming around. So you're going to notice maybe some swelling of the lower legs. You may have them particular patients on a blood thinner because now they're having trouble getting the blood back to the top. Myocardial infarctions. So they were going to talk about heart attacks. This is the classic symptom of a heart attack, are often not present in a geriatric patient. As many as 1/3 of the older patients have a silent attack, in which they're usually chest pain is not present. More commonly in women and patients with diabetes have the silent attacks. You may just have shortness of breath, or I don't feel so good. I feel like I got indigestion. Some signs and symptoms of cardiovascular disease. You have your dyspnea, epigastric and abdominal pain. Same thing. You think your stomach's hurting. You're just like, I just don't feel good. I feel like I just need to go to the bathroom. Be careful, and if they do that, because when they push, they can vagal down and pass out. So you have the loss of bladder or bowel control, and I don't necessarily like to look just for that one because that could be age related also. So you're nauseous and vomiting. Think outside the box too. What else could it possibly be? But don't let the idea of a heart attack escape your mind. So your weakness, your dizziness, your lightheaded, and syncope are some of the ones that you think about, but those could also be related to a stroke. You have your fatigue and confusion. They just don't know what's going on. I don't know where I'm at. So you can, even though we're talking outside the box on these things, heart attack does have these things, so symptoms. Some of the other ones are diaphoresis, pale, cyanotic, molted skin, abnormal or decreased breath sounds. And what are we going to do for them? We're going to open them, make sure they're able to maintain their own airway. If not, we'll put an adjunct in. Make sure they have good ABCs. If not, we're going to provide air for them. We'll be prepared with oral or nasal pharyngeal, maybe a King airway if your agency allows you. And then we're going to provide them with circulatory support. Administer aspirin or at least a patient administered nitro. If they have it, assist them in giving that medication. That's something that they need on board. Heart failure. Heart failure is the signs and symptoms will differ depending on the extent to which the right and or left side of the heart is not functioning correctly. So let's talk about right-sided heart failure. So right-sided occurs when the fluid backs up into the body. You will see jugular vein distension, ascites, and peripheral edema. So you start to see the swelling. And an enlarged liver may be present. We're not going to see that one, which is determined by palpation. We're going to feel it. We're going to feel for that, the quadrants, the upper and lower right and left quadrants. Right-sided heart failure is often caused by left-sided heart failure, so it is common to see both signs. With left-sided heart failure, fluid builds up into the lungs, so you start to have the trouble breathing. You'll have the fluid sounds in their lungs. If you listen, you can hear the fluid inside their lungs. This causes pulmonary edema with shortness of breath. It's going to be their number one complaint. Severe shortness of breath and hypoxia and crackles in the lungs. Told you what to listen for. So proximal nocturnal dyspnea is characterized by a sudden attack of respiratory distress that awakes the person at night when he or she is resting. So So what you may see are these patients that sleep in their chairs. If they sleep at a 45 or sleep sitting straight up, that's because they feel like they're drowning. Some signs and symptoms to look forward to or look out for is you have that coughing and it sounds really wet. They complain of suffocation. They have cold sweats and tachycardia. So their pulse rates accelerated well into the hundreds. Basically, the only thing that we can do is airway, ventilatory, and circulatory support. That's about it. That's all we can do at this point. And we're going to transport them to the most appropriate facility. So on a stroke, we're going to have the leading cause of death in elderly patients. This is a preventable risk factor. Preventable risk factors include stop smoking, hypertension, diabetes, atrial fib, obesity, and a sedentary lifestyle. They don't get up and move around. It's probably common. And then have uncontrollable factors include age, race, and gender. We can't stop that. So that is not something that we're going to be able to fix. That is not something that they're going to be able to fix in their lifestyle unless they get up and start moving. They got to be active. The more you sit around, the less healthier you're going to be. Signs and symptoms include altered level of consciousness, numbness, weakness, paralysis on one side of the body. You'll notice the slurred speech, aphasia, visual disturbances, headaches, dizziness, incontinence, and the worst case would be a seizure. Hemorrhagic strokes in which a broken blood vessel causes bleeding into the brain are less common and more likely to be fatal. Ischemic strokes occur when a blood clot blocks the flow of blood to the portion of the brain. So basically what's going to happen is your clot is just going to say, okay, well, you can't get blood in, you can't get blood out. So it's going to become stagnant right on the spot, or right pat, depends if it's blocking upward or downward. And you can't get blood back and forth. That potential part of the skull or the brain will die with due time. Determining the onset of symptoms of stroke is very important. How long ago did this happen? When did this happen? There's several questions you want to ask to see, are they within the golden hour of getting them to the facility where they can get the clot buster. That's something we look forward to try to get them, to try to help them and get them to their stroke facility in the most appropriate amount of time, because they need that medicine, and that's not something that we carry. A TIA can present with the same signs and symptoms as a stroke, and always manage the patient as he or she is having a stroke, because we don't know. We can just recognize the signs and symptoms, but we can't see if they're having a full-blown stroke or they not. We have to go off of what we find, what we see, and we treat that. So you're going to notice some changes in the nervous system. So this right here, these next few slides is what really shocked me when I was going over this today. It's just like, if you really process it, that's something that I'm not looking forward to. But changing in the thinking, their thinking speed slows down. So when they can't understand you, it's not that they can't hear you, it's that they're processing it a little bit slower. Their memory slow. The posture stability is the most common normal findings in elderly people. They start slacking. And the brain decreases in terms of weight. So 10 to 20% as volume of a person, it starts to shrink. That's crazy to think about that. So this increases the amount of space in the cranium and increasing the chances for a head injury. So you start, I mean, your walnut starts shrinking, and now you got a peanut, and then you got a lot of space up there that you potentially can get damaged. There's a 5% to 50% loss of neurons in elderly patients. Wow, that's crazy to think that. Unbelievable. This affects the control of the rate of the depth of breathing, heart rate, blood pressure, hunger, thirst, and body temperature. So you'll always wonder why your elderly patients, majority of them are skinny, because these neurons are not firing and telling them, I'm hungry, I'm tired, I need to take a deep breath. These things change, and you're just like, whoa, like that's crazy to think about that they now that understands and tells you why. Oh, there we go. Why things change, and it gives you another answer. Whew, on what's going on in this particular page. See my curtain back there, y'all? So their vision also, vision acuity, their depth perception and ability of the eyes to accommodate light will change with age. So a lot of times they may have to get glasses, adjust their glasses, I'm sorry, y'all. I know I'm not moving to mess with y'all, but I've got my feet on the ground and my elbows on the desk. The characteristics interfere with vision and make it difficult to distinguish colors. They're not becoming colorblind, it's just their eyes are changing and it's causing more issues. And this is going to increase the likelihood of slip, trips, and falls. They can't tell the difference in the depth of how far that step is. And when they go to step, they trip and fall. Also, think about this. It's harder for them to, their tear ducts, the production of their tears is dry. It's less, and they have more dry eye. You'll see a lot of times they'll take them off and rub them, or they'll have artificial tears. It's not because they can't, it's just the ducts are drying up and they need more assistance. Elderly people develop an inability to differentiate colors and have decreased night vision. So you'll notice a lot of elderly people don't get out and drive. They don't want to get out there on the road and go do a few things because they just can't see. So it's easier for them to stay at home. The inability to see up close is called presbyopia. I can't pronounce it. So. And it's caused by the loss of elasticity of the crystalline lens. A number of other diseases, process plague the vision of older adults, includes glaucoma, macular degeneration, retinal detachment. So I actually watched the video the other day on YouTube about retinal detachments, and it's crazy how often that they happen in your elderly. A sneeze can cause it. Good car wreck or some issues like that can cause a retinal detachment in an elderly patient, and they're scary. Those eye surgeries they're a lot better than obviously what they used to be, like a few other things, but they're still scary in how they do that and how often that they do occur. So their hearing, I think that's my problem now. So changes in the inner ear make higher tones harder to hear. Changes in the ear can also cause problems with balance and make more fall. You can have more fluid on the ear. That can also cause inner ear problems. Let's see here. Hereditary and long-term exposure to loud noises are the main factors that contribute to the hearing loss. When assessing your patient, check for the use of hearing aids or ask them, do they take hearing devices? Because they may have I forgot the name of it, where they plug into the skin with a magnetic and go over the ear. It's a hearing device. So make sure that they have those, or and ask if you can find them for them, so to help also in treatments. Taste. So our taste buds change every 7 years. So within every 7 years, things are changing. We may not like this anymore. We may just not get over the taste. Also, we may not be able to taste things because of that. So with elderly, the sense of taste can just diminish because of the decrease of number of taste buds. They don't grow back, and this can lead to listen to interest. They don't want to eat no more. Their loss of weight, malnutrition, and just plain out fatigue because they're not getting those nutritional facts coming out of the food because they just can't taste it. So if you can't taste it, then why eat it? That's probably their thought. So that's something to be cautious about. Touch. Think about this. This is what's nuts. Touch sense and the touch of pain to perception from the loss of the end of the nerve fibers. An elderly patient may be injured and not know it due to the decreased sensation of hot or cold. They just don't feel it. They may be numb to the area. They may be like, well, I didn't know I was bleeding because I couldn't even feel it. And you're like, how you not feel that? There's an elderly, one of our team leads out here. He can't feel his feet. He tells you, I can't. That's why I have to look at my feet when I walk. And his fingers, he got severely burned the last time home. Never felt it. Like, why are you still out here in the oil field? Oh my God. So let's talk about dementia. So the slow onset of the progressive degeneration, it's a shortened attention span, and it's a loss of conjective function. So they're just not. I mean, dementia is hard. It is chronic. It's a generally irreversible condition that causes progressive loss of just cognitive abilities, the psychomotor skills, and the social skills. I hope nobody has to deal with it, or even Alzheimer's. It's bad trying to do a normal functionality with somebody that's going through this, and trying to explain to them what you're about to do, how you're going to do this, and move forward. That's hard to try to get those abilities and try to treat somebody. So that's what sucks. Some potential causes in Alzheimer's diseases, Parkinson's disease, stroke, and just genetic factors. So some of the things you look for is determine. Let me get rid of this real quick so I can see. Or not. So determine the patient's normal mental status by asking questions. The family members, care providers, ask what their history is, but still don't ignore the patient because they know you're there. They may just not be able to answer efficiently to your questions. And what are some of their medications? What's currently their medication? So if you take this patient to a medical facility and they're not already on file or haven't been there in a while, that's the reason why we want to take those medications with us. So the patient might exhibit loss of cognitive function. Let's see, the patient may have short and long-term memory problems because of the decreased attention span, or they may just not be able to perform the daily routines because they're progressing backwards. They also may have a slow, decreased ability to communicate and appear confused, but allow them and give them the respect to be able to communicate. Now, that may not be able to answer your questions, or if they do, they come out in a just a confusion state. We're rocking pretty good right now. We go through these little spells where it gets worse and then it's okay. So, but give them the opportunity and try not to speak over them. Ask simple questions. Provide simple answers, yes or no. Shake your head up and down or turn your head. Just remind them some of those simple answered questions. And if you say, "Are you allergic to anything?" If they nod yes, now you just open the door to anything. Are you allergic to anything that's food based, medicine based? So, or they may say if you're allergic to anything that's in the environment, like bees, grass, stuff like that, and they can nod yes or no. So be cautious when you answer those, and they may just when they answer them, maybe a few minutes later, and you're like, sir? So just remember how you asked your questions, and that may answer your question at a later down the road. So delirium is a sudden change in mental status, consciousness, or cognitive processes. It is marked by the inability to focus, think logical, and maintain attention. This affects 15 to 50% of hospitalized people 70 years or older. That's just sad. It really is. It is usually the result of a reversible physical ailment, such as tremors or fever or metabolic cause. It's important things to look for in the history. What's something that stands out to me when I'm doing this assessment? Intoxication or withdrawal from alcohol, withdrawal from sedatives, medication conditions such as a UTI, bowel obstruction, dehydration, fever, cardiovascular disease, hyperglycemia, hypoglycemia, depression, malnutrition, and environmental emergencies. So again, there's a lot to think about when you start doing these assessments. You will be able to pick up and learn these the more and more you do them out in the field. So don't feel like you're like, oh my God, I gotta go learn nothing. I don't know what I'm doing. Well, we all felt like that. Remember, you're not the first one to have problems like that. So just look, listen, and feel. Don't fake it till you make it, but ask questions. Read, study more. I've told y'all, there's many times that I'll sit down and read before I come in here and prep to teach the class. It's because I want to know the new thing. I want to know the new and upcoming thing that you guys are going to face versus what I faced 20 plus years ago as a basic. Is the same, but there's been new things that's come out. What can we do different? There's new assessment skills. So just make sure if you pick up somebody and they have something, just read about it. It may come back to play on you later on. So assess and manage the patient for hypoxia, hypovemia. That has just messed me up. I'm done. I can't get it. Hypoglycemia and hypothermia. We can fix those. Let's fix that, and that's something that we can do. You may see changes in circulation, breathing, breath sounds, motor functions, and your assessed pupillary responses. They may be slow, they may be fixed, but check all those signs and symptoms out because that's building your assessment and to help you treat your patient better. There's a table on syncope. And just always assume that it's from a life-threatening problem until you can be proven otherwise. That is just a smart thing to do because we don't know. So let's make sure that, has this ever happened to them? Let's ask the right questions and get them transported pretty fast. We don't want to stay and play all the time on scene to move forward. This often caused by an interruption of the blood flow to the brain. So think about it that they just had just a loss of blood functionality, that something caused that problem and we have to fix it. Hang on. I'm sorry. I don't know what has caused this again. All right. Can you guys see the chart on syncope again?
Not yet.
I can't even. You'll just see the main. I don't know what's going on. Face. Isn't that pretty? No comment.
Yep, just see you.
Yeah, I have no idea what's going on with my electronics here. Let's try this again. Watch, it'll work for another 20 minutes and then it'll decide to do its own thing. I don't know how it can lose connection when it's sitting right next to it.
See a screen that says neuropathy.
Yeah, and I can't scroll over to it. Whoa. All right, so I can't even get to my Zoom screen. Hey y'all, I'll tell you what, let me just reset everything. So take like 5 minutes and I'll be right back. I'm sure y'all will hear me talk. Because since I can't mute anything, I don't know. So y'all give me just a minute. I may have to figure something out here. I'll let y'all stare at my other pretty face. How about that? So I think we've lost my video part. I don't know what has happened to it. I can't share my screen no more. Y'all hang on 1 second. Guess I'm just gonna make an executive decision and y'all just have to listen to me. I'm so sorry. I don't know what else to do because when I try to share my screen, it keeps telling me it doesn't work. So I have a feeling that's because of how bad the weather is out here. So that may be why I'm unable to share it. But so anyway, I'll just go through some of the things, and I'm sorry, we'll have to figure that out. So the changes of the skin. So think about the elasticity. So you're gonna have ours is pretty thick now. Ours has more of the flexibility, and it's the largest organ that we have because it's constantly growing, constantly it sheds off, and that's how we develop new skin all the time. So the layer of fat under the skin also becomes thinner because of the redistribution of the fluids and the proteins. So bruising is very more common, and the skin can tear a whole lot easier. If you've never seen a skin tear from an elderly patient, that it gets a little rough sometimes. It's like, oh, you deal with those a lot more than just anything else, and trying to figure out how to treat the patient, and you don't go from normal just plastic tape, you go to a cloth tape, because at the time, what happens is the regular plastic tape will stick to them versus the cloth tape. The cloth tape will not stick as much and not cause skin tears. So that's a really good part is you don't, I prefer cloth tape over regular plastic tape more than anything else. And if y'all don't have cloth tape now, it is a good thing to get cloth tape in your ability, because that's just another tool in the tool bag. It's easier to use and it doesn't cause harm later down the road. So you'll have ulcers too. So when we talk about that, is like a bed ulcer, an issue like that. So stage 1 ulcer, that is a non-balancing redness with damage underneath the skin. So it'll kind of look like a early stage of a zit. So then a stage 2. So this is a blister ulcer that can affect the dermis and epidermis. So now that it's starting to rise more to the top of the skin, you'll start to feel a fever. You'll start to have a lot more redness. You'll get that dome type. So stage 3 is an invasion of the fat layer through the fascia. And then a stage 4 is invasion of muscle to the bone. So you progressively get worse. So stage 1 is very easy. That's something that you know that you're starting to get a bed ulcer from and that they can treat. Now, stage 4, so stage 4 is the worst. So now you start to have the bone and the muscle starting to eat, and it's starting to take away from that. So you may start to have those issues where you may have an open ulcer to where you can actually see the skin deterioration, the pus, the bone. It could eat all that down. It kind of reminds me of like a brown recluse. I know that's kind of bad, but that's just kind of what I think of it. So toxicity. So now we already talked about when they take these medications and they're starting to slow down due to the progression of the stomach, how things the kidney functions are starting to be lower. So when we talk about toxicity, so we talk about, whoa, my screen's changing. Nope, I don't know what to do here. So decreased kidney functions again. So you'll have the altered GI absorption. So it's going to take longer for things to be absorbed into the GI tract. You'll have the vascular flow of the liver is going to be decreased. So the kidneys going to undergo many changes with age too. So things are slowing down. Now it's not going to stay as drastic at age 65, but the older you get, you know that the body's going to start slowing down, and we're not going to be able to take certain type of medications without a prolonged exposure or prolonged side effects. So the decrease in liver functions make it harder for the liver to detoxify the blood and eliminate any substance that's such as medications and alcohol. So they may actually get that 24-hour buzz, or that 12-hour sleep medicine, or the 8-hour sleep medicine may take 24 hours now because of that. Some of your typical OTCs, which is your over-the-counter meds, can have negative effects when mixed with each other. Like maybe a herbal substance that they're over-the-counter. Any form of alcohol may issue, because we've all had that medication that says may prolong exposures if mixed with alcohol. Well, you may drink it, take it, and you go to get a beer later on, and you're like, wow, I'm so intoxicated. And then you remember like the next day when you take the pill again, you're like, oh God, my bad. So be cautious when so my thing is when I do these, when I do my assessments, I'm very detailed on how I ask, what have you done in the last 24 hours? What new medications have you had versus the old ones? How long have you been on them? When's the last time you ate? How much did you eat? What is your urine output and what color it is? Because what that's telling me is how often they're peeing off stuff. And then once you get personal and they start telling you, well, when's the last time you used the bathroom, sir? And then you can start figuring some other things on their medications may help out. Polypharmacy refers to the use of multiple medications by one patient. Well, we all know geriatrics have like a suitcase full of medicines. So negative effects can include overdosing and the negative medication interaction. Medication non-compliance in older patients is also an issue, and it may occur because of financial issues, the inability to open some of those containers because they're already a pain in the butt now, and an impaired cognitive ability, which is vision and just hearing what they're supposed to do with that medicine. It's I always like to if I don't transport them, I like to make sure that they understand it and have a educational process in that to make sure that they understand, hey, I know you put all your medicines in this multi-day hour by hour box. That's fine. But are you sure you know what you're putting in there? Because if two of the little blue pills look just alike, they may not all be take one at one time. It may be supposed to be taking one in the AM and they got it confused. So be cautious about that. Try to see if you can dig deeper into figuring out what really is going on. So we deal a lot with depression. So your elderly patients go through depression. They have thoughts of suicide, depression because maybe a significant other has passed. Now that they're by themselves and they just don't know what to do with themselves. I'm dealing with that with my father right now since my mother has passed away. My dad deals with he won't ever tell you he's depressed, but some issues like that we deal with to where we don't know what to do sometimes. I have no idea. I've never been in that situation. I have pity for my father because I mean I know my mom she's an awesome person. They were together since high school. So think about that and what to do with those patients that show signs of depression and how am I going to treat them and what am I going to do? Some of the things you can think about is when you start asking these questions, do they have history of depression? A recent loss, a traumatic loss, any type of substance abuses? Do they isolate themselves? On prescription meds, do they have any prescription med for depression? Or if they do, are they taking it? Maybe they have some chronic medical conditions that we don't know about. So suicides fall in that same mental health crisis that we have in our elderly patients. Most older men have the highest rate of suicide in the age group in the United States. Older patients who attempt suicide choose a much more lethal dose than the younger victims and generally have diminished recuperative capacity to survive any attempt. So even if they do shoot themselves, they're not going to survive the long run. It is, and most of these suicide attempts and cases are victims who've recently had that major loss in the family. They have been diagnosed with a terminally ill thing. They do suffer from depression and have seen their primary physician in the past month about what's going on, and maybe they just didn't know how to do it. Maybe they just didn't know how to express that they have depression, or if they did, they feel like it's a cry for help and they feel weak. When assessing a patient who is displaying signs of depression, it is appropriate to ask if he or she has thought or is considering suicide. If the answer is yes, your next question should be, do you have a plan? And at that point, as soon as they say, yes, I have thought about it, and if they don't have a plan, maybe they do and they don't want to tell you, but that's their cry for help. That is, they're reaching out saying, I need somebody to just help me. And then you have to report that, and now you have to transport that patient and treat them. So we have the mnemonic called GEMS, GEMS. The GEMS diamond was to help to create you remember about older patients. So G stands for geriatric. Consider that older patients are different from younger patients and may present atypically. Be familiar with the normal changes of an aging and treat older patients with compassion and respect. E stands for environmental assessment. M stands for medical assessment. S stands for social assessment. And that's it. So consider special considerations in assessing geriatric patients. Now, again, we talk about communication issues. We're not saying that they have trouble talking. We have an issue with our communication. It's about hearing and vision defects. That may be what our communication problem is. They may have alternating between inconsciousness and out of consciousness. They may have very complicated medical histories, and we're like, I don't know what I'm doing. Hey, I don't know what I'm supposed to do. And then you may have prolonged effects of certain types of medications. We'll talk about that in a minute. Let's see. Let's skip. Trying to say because skip to that, and we'll do that at the end. So when we talk about trauma and elderly patients, know that they do have a limited physical reserve, if any, of blood, the will to fight, the energy, because they're just tired. I mean, the normal effects of aging of the body is existing. Medical issues may be your biggest complication. The mechanisms are so much more minimal that causes much more damage. They may have recuperating from trauma is longer and less successful because the elderly is just not. The healing process is much longer if they do heal. You could have everything done in the best interest and a change of the patient's status by the time you get the patient to the hospital, because you did everything you could. But during the outcome of their stay in the hospital, they're probably gonna get pneumonia. They're probably gonna die from that secondary injury. And it's nothing that you did. It's just because they don't have the ability to fight off those issues as we do as younger ones. Older pedestrians are more likely to have life-threatening complaints after being struck by a vehicle. Again, we know they can have secondary impacts, can also be serious injuries once they hit their head and they fall and hit the concrete. Those coup effects and the swelling of the brain. And remember, that's going to have much more swelling before we notice it, because they've had that much parts of the brain have already shrunk. Let's see, the risk of mortality from burns is super increased. They do have pre-existing medications that's medical conditions that's going to affect their ability to heal faster. We already know that their immune system is weak because it's not able to rebuild as fast. And remember, when we talk about fluid replacements, that's something that's already compromised, because we know that the kidney functions are lower. The ability to return blood and clean by the liver is going to be affected. So coming around from a traumatic injury is a struggle. You're on the back end already, and it's super hard to get on the front side of that. They do have a higher mortality rate in trauma than regular adults, especially GSWs. It's just, it's not. Penetrating trauma can easily cause serious internal bleeding. And that's just something that it's going to struggle. We're going to struggle to fight to keep that condition on the improvement. Geriatric patient overall physical conditions may lessen the ability of the patient's body to compensate for the effects of multiple simple injuries. Osteoporosis presides in older patients, and hip and pelvic fractures. Let's see, compression fractures of the spine are a lot more likely in geriatric patients. Let's see here, because of the brain tissue shrinks with age, older patients are more likely to sustain closed head injuries such as the subdural hematoma. We just talked about that. Due to the slip, trip, and fall, now we got to know that there's that much more swelling that's going to take place. Acute subdural hematomas are among the deadliest of all head injuries when you come to geriatrics. Other factors predisposed of older patients and serious head injuries include long-term alcohol abuse, recurrent falls and repetitive head injuries, and anticoagulant medications. So they're just free bleeders. They're just not going to coagulate because they've taken so much blood thinner, and you're like, oh my God, that's 7 blankets I've got on. I'm trying to hold the blood. Well, now you just soak on all their blood up. But there's nothing that we can do about that. In environmental changes, just know that it's going to be super hard for them to compensate to the outside environment. That is not something that they're going to be good about. Half of the deaths from hypothermia occur in older patients. Mostly indoor hypothermia deaths involve geriatric patients. Death rates from hypothermia more than double in older people compared with younger people. People older than 85 are at the highest risk of deaths from hypothermia. So let's talk about scene size up. So what we're going to do is we're going to look for clues that that show that the patient's in a traumatic incident have been perceived by medical condition. Bystanders can help you. The MOI super is important because it establishes whether the injury is considered critical or not. Address major life threats. We know that that's going to be the number one thing. And then now we're going to turn around and say, what is our transport priority? Because now transporting is going to be at the higher end of our, because we know that geriatrics are already on the back fall. So we want to try to get them there as fast as we can. We're going to have our general impression. We're going to make sure we form an APU. We're going to get our GCS, and it's going to help us determine their mental status. ABCs, are their airway and breathing patent. Older patients have a diminished ability to cough, so suctioning is very important when you're getting ready to assess these airways. And assess their area for dentures. That is super duper important, and we don't want them to potentially choke on a denture, or if a fake teeth has been pooped out. We want to be able to try to get that. Manage the external bleeding immediately, because we know there's only so much blood that they can lose. So we have to be able to control that. Our older patients are going to go into shock much faster because of their blood loss and the ability to coagulate. Patients who are hypertensive prior to an injury may have a normal blood pressure, but when they are actually in shock, because that's what they normally function off of, and they're losing all this blood to maybe an internal bleeding, and it's just like, I don't know what to do. Investigate the chief complaint. Considerations in your assessment must include past medical history, even if they're not currently acute or symptomatic. What do we see when we see them? Performed in the same manner as we're going to do for any adult, but consider the higher likelihood for damage of trauma. Any head injury can be life-threatening. Check for lung sounds. We're going to listen to all the 4 loads, or we'll front and back, top and bottom when we do it, and look for bruising or other evidence of trauma, because it's going to happen that much faster, because we know that their skin's already weak. We're not going to be able to contain the bleeding. It's going to happen rather fast. Vital signs, that is, remember, cap refill is going to be unreliable at this point because of the compromised circulation. It's just not going to be able to be there. And remember that some older people take a beta blocker, which is then inherit their heart from becoming tachycardic. So it's going to produce a slower heart rate anyway. So remember that if you happen to hear them say, I'm on 2 beta blockers, you're on a what? Because now that means they're going to have much more slower heart rates. Repeat the primary assessment. If they have any broken bones that are common that should be splinted, splint those as we're doing our reassessments there. Do not force the patient with the joint flexion into a normal position. If the leg is already bent and my other one is straight, don't force this one out. That may not go that way. That joint may be locked. You're going to provide blankets and heat to prevent hypothermia, but pad that area. Make sure when you do it that the patient is comfortable and as comfortable as possible, but pad that area that is in the flexion so that keeps the joint from bouncing up around. And it's just overall more comfort. On our reassessment, make sure you communicate and you document what's going on. Communication can be challenging, we know, but just do your best to continue to communicate with the patient on what's going on and how things are proceeding in their care. Infection controls, that needs to be very predominant in what we're going to do, because think about, if there's an open wound, we need to make sure we try to close that early. Response to nursing homes, assisted livings, and things like that are going to be pretty high in your career. So think about, not saying that you should, but you need to think about MSRA, MRSA when you go to these facilities. They may require you to gown up, but if you don't have to go in there, then don't go in there, because it reduces your exposure to these. It is the respiratory virus can cause an infection of upper lower respiratory. So just make sure that you have gloves, mask, gown, that when you go to take care of these patients. And again, just tell them, hey, look, we're just doing it for your safety. We want to make sure you stay healthy, and just be very open and talk to them and tell them what's going on. Typically, alcohol-based hand sanitizers do not kill the MSRA or the C difficile part of the MSRA. So we talk about SARS-CoV-2. We know we all be geniuses on this right now. We do know it's spread by person to person through droplets. Coughing, sneezing, shaking hands, touching metal, breathing, function through life will expose you through that. So when we talk about dying patients of the elderly, so we're on the end of it. So dying patients should receive palliative care. Be understanding and sensitive and compassionate when dealing with the family and the patient. Determine if the family's wishes for the patient to go to the hospital or stay at home. That's touchy, because it's just, I think we're going to talk about this later. So here it is, advanced directives. So you have full code paperwork. You have do not resuscitate. I can speak just for the state of Mississippi. So in the state of Mississippi, if a DNR is not updated every 90 days, technically it has to be reapproved by a physician for it to be in date. Now, if my sister and I have a DNR on my father, well, if one of us are both on site and if both of us are there, and if one of us does not agree and to say no, or says, no, I want my daddy to be worked. Well, now you're in a catch-22, because the paperwork is agreed on both of you. Now one's throwing it. So it's best to reach out, call med control, let your doctors know what's going on, and be very informative and be like, hey, look, just like you know, the DNR is in date, it's good to go. But now family's starting to argue about it. You have to try to get them to agree, and maybe let the doctor talk to them. If you give a DNR, so it's do not resuscitate. It does not mean do not treat. So basic care of ABC still should be provided, but you can't just sit there and let them pass. If that's something the family does, now you can say, hey, what would you like us to do? We can assist them in some ventilations. But if we start doing full CPR mechanisms, we're going to have to take them with us to the facility. And if that's not something you want, please let us know. And also, may have to, sometimes it may not be you having to tell them that, and inform them. Be like, listen, I know y'all are not in agreement right now, but you need to understand that when I sit here and I'm fixing to do CPR, we have to make sure that it's done properly and by standard. And I'm potentially fixing to start breaking some ribs or break their chest, and I don't want you to see that. Either if that's the way you want us to go, you want to ask you to step out of the room, and we're going to load them up and transport them to the facility. Now, Then the family will say, no, we don't want that. Okay, well, I tell you what, we're gonna help dad. We're gonna put him on some oxygen, and we're gonna try to help him out just enough to where he's comfortable and he's not struggling for breathing. So the bedside manner is where you gotta kind of, by no means do I mean sell your case, but explain it to where family understands better. If again, if family does not agree, you need to explain to them, since you do not agree, and I do have DNR orders, I am going to have to initiate resuscitation and I will have to transport them. A lot of times that will try to sometimes fix the issues, and sometimes you're just going to have to transport them because they can't agree. Now, that's a fight that they're going to have to deal with later on, not you. Talk about neglect and abuse real quick. Remember, it's not always physical. It could be emotional. It could be due to nutrition. It could be a lack of providing food. And just taking things away from them may be abuse, as in like, you know, grandfather, you're not able to drive anymore and you steal their car. Well, you realize when they were young and they've worked their entire life, they didn't have anything as kids. Some of these grandparents went through the Great Depression. And now you're taking things from them so they don't sit well with them. That's hard. A lot of times the elderly don't report the issue, they don't report the abuse because they're scared to, and they're ashamed that they're dealing with that and going through that issue. Elderly abuse occurs more often in women older than 75. Abusers of elderly people are sometimes products of child abuse themselves. And the abused person may feel traumatized by the situation or be afraid that the abuser will punish him or her for reporting the abuse. So that's the reason why they don't report it. Talked about that. Signs of abuse, the same thing. That's something that you have to report. Signs of physical abuse may be traumatic evidence, maybe bruising, maybe missing of hair, sexual abuse. Geriatric patients with altered mental status may never be able to report the sexual abuse. And many women do not report cases of sexual abuse because of shame and pressure, and they may be pressured to forget what happened. That may be something that unfortunately that we face and that they see. That's sad that that's something that's going to go on. That's all we have for the class tonight, y'all. I'm really sorry. I'm having technical issues over here. I'm sliding around, and y'all get to see me move and bounce up and down, but it's pretty rough seas. Guys, that's it for the class. That's your last lecture of this program. So anyway, I talked to you all about the final exam. So let's talk about that. So what we try to do is your final exam will be proctored at your last boot camp. So at your boot camp, you need to make sure you take a computer. However you do your final, however you take your test now. You'll still be given the allotted amount of time that's on a computer for you to take your test and all that. But that's the reason why we urge everybody, they have to go to the boot camp, because your final exam is being proctored there at the exam. And it's not to punish anybody. It's not anything like that. It can help us and help you. This is something that's done there wherever your boot camp is with your instructor. And it's also time for you to ask questions prior. Let us do some last minute final studying with you, and that's our jobs. I know that unfortunately I probably have never met half of you folks on here. I feel like I know you all. I've wished that I could be at a boot camp, or we could do something where I could meet you all, because y'all sound like some fine individuals. But again, that's life. We all live in different parts of the world, and thank God at technology, and that we're able to have classes like this all over the country, and doing what you do. Thank you for what y'all do. Thank y'all for being here this entire semester. I know it's been frustrating sometimes. Thank y'all for working with me. It's been a pleasure working with all of y'all. At the same time, it's a learning curve. I learn something from every different class that I teach, and I like to adjust things. Like now, we're learning how to adjust when my computer won't show you all the slides. Other than that, folks, your class is done. There is, I don't know why it's going through. Let's see here. There is your code for the class. That is your attendance code. All we're going to have reviews, Leah says. That is not something that I have planned. If that is something you guys wish to, I am not unable to do it next week when I go home. My wife is leaving town and I am going to be a full-time dad for almost 10 days. I will not be able to because I'll have 3 kids to manage, and it's kind of hard when I'm the only one. Joseph, if you can't see the code, that means you do not get to take your test. No, kidding. It is all caps, finally done, with a space in there. That is the final code. That's your attendance code for the night.
So
Leah,
how many questions? My bad.
No, this
That's
is
my
just
question.
So
How many
just your
questions?
chapter test. On which one?
The exam.
So the final. I don't know. Give me just a second. I'll look. I don't remember. I did it the other night and I couldn't tell you. Let's see
You
here.
said it
So
was
give me just a
very
minute.
lengthy.
So I did say that.
What is 100?
Let me look real quick.
45 would
Hey,
be
man,
nice.
remember, there's Marines in this class. We're used to eating crayons, not taking exams.
I understand that. I've worked with several and I have taught several. So nothing wants to work in my world tonight. Like one of my screens on my desk is gone now. It's just not working. Let's see here. It kills me that something can work just fine and then it goes to sleep and it doesn't come back on.
Sounds like my
There
daughter.
we go.
Yeah.
Bro, it works fine. And now, let's see here. My account.
So, Chris, I got a question. Do we have a specific time limit to like set it up as long as we get it done? Like with training and boot camp or different things like that, as long as we get it done prior before like the end of November out or something like that, or we have like a specific time when we have to set everything up for
Oh, just so y'all know, I didn't save it the other day when I set it up, so I have to go back in there and create the file again. Most likely, guys, it's probably gonna be anywhere. Oh, Bryce, I knew you go talk something. So what's probably gonna happen is it'll be between 100 and 150 questions. Because there's so much in this class that needs to be questioned and needs to be asked questions. It's so hard to say I can give it to 100 questions. I'll try 100 questions and see how it looks when I go to take the test. Because every test I have built for you guys, I take the test. I do not. I just don't produce something and without taking it. I want to make sure that if I miss something, I go and look. If it's not something we covered, I change the question. So in each class, I change the test out. Is there going to be? Hold on. So Samantha asked, what will be the time limit? Is there going to be? So Samantha, yes, there will be a time limit, like there is on every test. I do this. The reason why we do that is because the National Registry is time limited. I promise you I will be nice to you. I felt like I have tried to be nice to all y'all on the time limits. I know that some don't think that, but I promise you you'll have enough time. And now, is there going to be emphasis on anything specific? So, Rose, what I normally do is I normally choose random questions from different chapters. So I can go in there and build it. If I want to build 99 questions on trauma only, I can do 99 questions on trauma.
Yes, do that.
What I try to do is let the computer randomize X amount of questions from each chapter. That way and then I put them in random orders. I don't know if y'all noticed, well, in your mod test, they should all be in random orders.
Yes.
You may have a question on pediatrics the first, and then you may have a question on legal the next. So I do that because that's how registry does it. I wish I could do progressively questions to where they get harder as they go, but I can't. I have not figured that out yet. JB Learning has so many different opportunities and questions for us to do things on tests, but I haven't figured it out yet. So I just normally select, if there's 10 chapters, I do 10 questions from each. That makes sense to y'all?
Yeah.
You guys, why I got you nervous? Don't be nervous, Samantha.
You keep on saying that, I'm nervous.
So I know everybody's nervous because it's the final. I'm about to get it. I completely understand. I will say this. In the past classes, 90% of the people that pass the final will pass registry. And it's not like I'm not trying to pick the questions, just how good JB Learning is with their questions. So it's going to be like passing grades like everything else. You got to have a 70 to pass, and that is a 70 to pass registry. Instead of doing the 75, I changed the final to a 70. So, I mean, it is what it is. I mean, as long as you've passed and you're at this particular point, y'all some smart individuals. I mean, you're not some average crayons there. Y'all pretty bright. So I will probably build this again tomorrow. Myself or Rob will take the test, and we'll change here, change there. So yes, there will be retakes, but I'm not gonna give you an open book for retakes. If that makes sense? I'm not just gonna I'm not gonna give you unlimited. And the reason why is because the same thing with registry. I hope you guys know, registry you get 3 chances, then you have to take a refresher, and then you take 3 more chances. Once you fail the 6th time, you go back through the entire program of the EMT basic program. That's registry. That's how they do it. That's the way it's always been. So yes, Leah, you will get an option for retakes. I can't tell you how many S's there's on the retakes that there is.
Would be that same day, like
I'm just not
couple
gonna
days.
Yeah, I mean, I know I'm a hard ass, but I'm not that mean. I want y'all to be confident. I will be more than willing. Like I said, once my wife gets back home, I'll be more than willing to help you guys. But I have my hands full with my 9-year-old by myself, so it's gonna be hard. So literally starting Tuesday when I go home, I'm kind of gonna be out of pocket. I will double tap Rob to potentially be, if you guys want to like a refresh or sit down and talk about anything. But again, we have Discord that y'all can, and there's a particular study group, y'all can ask past and present students of what's going on. I don't know if y'all saw the message that Rob and all of us are gonna look about putting a study group for different chapters. Now, that's not something that's included in your current expense. I don't know what the expense will be for that. Like I'll pick on Reginald. You say you hate peds, so if that's something that he really wants,
taking care of. If my question is nothing but trauma, I'm a pass.
Well,
I need all my
I'm gonna make
questions
you
be
just
nothing but
repeat
shock trauma.
questions. So if that's something you guys want, I know Rob has put that out there that you guys can sign up for the class. I don't even know how you pay for it. I don't know them details. I don't get into that depth of it. But I have no doubt you guys will do very good. The 7 of y'all are gonna do fine. I know y'all are gonna freak out. Literally just think about what you put down. Don't second guess yourself and don't over question yourself. If you know you read a question and you're like, I know that's what it is, put it down. Okay. I've lost too many
And you
good
said it's
students.
on the
Some are
7th.
here, some are not.
There's an exam on the 7th, you said, or the 6th?
I know. So I have it to open on November 6th. It's just set for opens at 8 a.m. and closes at midnight. Now that's not. Don't think you're like, oh God, I got to do it all day long. Man, you need to send me a private message so I remember what I'm talking about there. So just because it says 24 hours, that's fine, but you still remember you have to take that at boot camp. So you will get a lot of time at your boot camp. That's why I've got it locked now. If yours is not the 6th, I can go in there and let's say Samantha and Caesar go to the same one, and then the other one, the other few of you go to a different one. You can't take it on the 6th because I'm gonna assign who goes to what opens on this date. Does that make sense?
Yeah, that makes sense.
Yeah.
And just so y'all know, just because Colby's looking at one answer and Reginald sees another answer, I have had this happen before. Y'all pass answers around. That's cool. That's fine. We don't know these things, but I can see it when you take your test because I know how fast you get your answers. And remember, they're random, so they change. I get 10 random questions for each individual test.
That was my next question because I
So-
was actually talking to my coworkers that took the program in the past. Actually, a guy just took it with Rob. I think Rob was his instructor. So in case I can't make it on that boot camp day and take my exam, he told me what Rob did with him. I don't know if you ever did this before. He proctored him through Zoom if he couldn't make it.
Yep.
Because since we work on a
There's
different
things we can
shift,
help
so
y'all out. There's things
I don't know
I'm
if I'll be
telling
able
you,
to make
there's
it. That's
so
what I'm
many
trying to make
options
sure.
out there. Yeah, there's so many things out there that we can make things work. And don't forget, I know people in your neck of the woods. So
Yeah, you do. So that's
and
what I'm saying.
Reginald, I know some people that up and around Memphis fire. So and I know some folks that up that way too that we can.
That'll be wonderful because, like I say, I'm good. Like I can tell, like in the beginning when you start talking about, you know what I'm saying, when I had took my little course at Regional 1, and when they would certify us through the hospital as EMTs, I noticed in the beginning, I'm like, okay, now I forgot all about the basic stuff. And then when we got like towards the end with trauma, I can tell my weakness and my strength. I mean, my weakness and my strength. And I'm gonna tell you something, the pediatric, I forgot all about it. Forgot all about it. Because I don't do pediatric I do shock trauma.
Because you had a mental block.
Yeah, I had a mental block really extremely bad.
Well, again, folks, it's okay. It's okay to reach out for help. Y'all know how to reach me on Discord. I've at least talked to every single one of y'all through Discord. So I do answer my messages, and it may take time for me to answer them, but I will answer you. I can do almost 90% of the stuff I need to do from my phone. I just can't sometimes access JB Learning from my phone. So I had to get my computer. That's why I carry my computer at all times, except when I go to the deer camp, so in case y'all message me and I need to fix something. If it's on the weekends, I may have to wait till Monday because I do family first. But as long as I'm at work, I'm almost 24 hours as well. You give me about 15 hours of the day. So guys, again, your test should open up here in the next 2 hours. Get y'all some sleep, rest up. Y'all need to review your stuff, and you can take your test tonight. How do you recommend us to reread? So I am a visual person. The way that I did prepare medic school is, I know it's not gonna help you now, but when I did my class, and I went through my class, I would retype my entire chapter after class was over. I would go back, reread, and I would sit here and just look at my book and type it. I was a visual learner, and I had to do physically, I had to touch it, and that's the way that I touched it. I would suggest taking your national registry sooner than later. The more the time that you put in between, you're not gonna do so good. And you progressively lose things. How do you restudy for your final? I would suggest if you look at your grades, if a area that didn't do so hot, I would study that area stronger than the other one. By no means am I picking on anybody, but they make this really good book. You know, the 4 Dummies series, EMT for Dummies. I have the book EKG for Dummies. I reread that very regularly because I don't use EKGs a lot and I forget because we don't do that much out here. Even though we just really bad had a penetrating trauma the other day that was pretty messed up. But I like the 4 Dummies series. I actually have that for the Mac book because I was having trouble when I first started with my Mac. So Leah, to answer that, maybe that's on your. I mean, it's how you learn. If I would look at the tests that I did not do so good in, and I would go back over that chapter. Y'all know y'all have access to the audio and the videos that we've done. You can listen, fast forward, rewind. You have that ability to help with your studying. But I don't know how to answer you that on that one, Brian.
All those chapter tests that we took, are the reviews, or like when you would go in and review it, you see the questions you did well on, it has the answers, and the questions you didn't do so well on, it's got the answer as well. Are those going to be open for us to review?
I haven't locked anything.
Okay.
Can you see them now?
So I don't know. I have to go back and look, but I was just curious. I didn't know if you were going to close all that.
They're not.
They still unlocked.
Okay. Yeah, Joseph, I am not going to take those away from y'all. So if that's something that is open, please, I promise you, I'm not going to go in there and crash something from you guys to look at. I have
So we can go
course EMT book. We come to practice.
So we can go back and look at those quizzes we took and review them. Because that was my next question.
I am not going to delete those from you guys.
Okay, because I know when I was at the academy, when we took our final, like the quizzes we took, some of the questions from the quizzes, they were on the final, but like they were worded differently. So I don't know if you like randomly pick questions from that, or because I just need to know what I need to study and like reread and just look up.
He tried.
I'm just trying to study.
I just need to give you my Venmo now. I mean, what's the deal? What you need?
Bruh, I just need to know, man. Because like I told you, like,
yeah,
I need to know.
Joseph, I didn't hear you. I'm sorry.
I said, if that's an option, I got paid today.
I feel y'all.
I get paid tomorrow.
So listen, I have too many people offering to pay me for these COVID tests here lately, but if you can make me hot, I really appreciate that. Listen, guys and gals, I'm sorry. So going forward in the next classes, just to let y'all know too, that we will be doing the final test that we'll be pushing for out. I forgot the name of it because Rob and I just talked about it, but it is kind of basically what you said, Rose. It is a crash course. It is a final test out, and if it's a proctor, if you make anywhere between the 700 and 1,000 range on this test, you will pass registry on the first time. That is going to be more of our that's going to be the next going forth now. No, that didn't help y'all. Y'all are doing fine. Y'all done fine. Not everybody's going to pass every single test. Not everybody's going to be passing with flying colors. But take some deep breaths. I promise you guys. I will work with you. I will help you as much as I can. And again, I'll bend over backwards for everybody that I help, and I don't limit it to just one particular person. I'll help everybody out. That's all I know. Take a deep breath. Again, I'll be working on the test since I obviously didn't save it. I'll have to go in there and fix that. So I will let y'all know once I finally get done on how many questions are on your final and how many that I'll give your allotted time, and we'll go from there. Remember, less is more. Smooth is fast and
Chris.
fast is smooth. How about that?
Yeah, I heard it all the
All
time.
right,
But
so
all right.
we're good to y'all. I tried. I feel like I've been good to y'all for a while. Hey, Joseph. All right, folks. Listen, please don't forget your class code, and I hope y'all have a good evening. I'm gonna go try not to slip, trip, and fall in the shower with the way things are rocking, and I'm gonna knock out. I gotta get up at 4 in the morning. We got early flights and COVID test tomorrow. So best wishes to all y'all. It's been a pleasure. I hope to meet all y'all in some form or fashion. If y'all need me, please reach out on Discord. I'm always here by computer, at least until while I'm at work. If y'all, once I come back to work in 2 weeks, if y'all need something, please hit me up and we'll go over it and we'll get back on here and I can lock the room. It can be just us two. Other than that, good luck to y'all. It's been a pleasure, and I will hopefully see y'all at a boot camp one day. So
All right,
y'all
man,
have a
take
good
care.
night,
Thanks a
y'all.
lot.